Hello everyone and welcome. Today we are discussing physical therapy in Parkinson's disease. So Parkinson's disease is a condition that was first described by James Parkinson's over 200 years ago. However, the disease still is widely misunderstood globally. So whether you are a patient living with Parkinson's disease, a caregiver, or a clinician involved in rehabilitation, this session will help you understand how physical therapy plays a critical role in maintaining mobility, independence, and the quality of life. And here is the most important message. Movement is medicine in Parkinson's disease. So movement is medicine in Parkinson's disease. So let's understand what Parkinson's disease. So Parkinson's disease is a neurological condition that affects movement control. It affects movement control. It happens because certain brain cells that are responsible for dopamine production gradually decline. This dopamine production occurs in the substantia nigra. Substantia nigra is part of the basal ganglia or the basal nuclei, and it is the substantia nigra that is responsible for the production of dopamine. So Parkinson's disease will happen if the brain cells that are responsible for dopamine production, specifically substantia nigra, gradually decline. So dopamine helps regulate smooth movement, coordination, and postural control. So smooth movement usually occurs when there is synergy between the flexors and the extensor muscles. For example, if I were to do elbow flexion, there is a smooth movement only if there is synergy between the flexors and the extensors. So that is what happens with smooth movement, and that is a role that is played by dopamine. Dopamine is a neurotransmitter or a hormone. Then coordination of movements. Dopamine also helps regulate coordination of movement. So this is just about the precision of the movements that we do. For example, if I were to do finger to head, this is only precise if there is coordination, but in Parkinson's disease, we'll find that there is no precision in coordination of movement. Then postural control. How are you able to control your posture? Are you able to control your walking posture, your sitting posture without any problem? So those are some of the things that are regulated by dopamine. So I've said dopamine helps regulate smooth movement, coordination of movement, and postural control. So the common symptoms that are associated with Parkinson's disease include tremors. And with tremors, it is usually the resting tremor. So this is whereby you find there are tremors in the hand. There are tremors in the hand, involuntary movements, abnormal movements that occur in the hand, and it's usually the resting tremors if there is no activity. But if you give them an activity to do, in some patients the tremors will decrease. Then muscle stiffness. The muscles become rigid, they become stiff. Example, we have the lead pipe and the cogwheel rigidity. Then slowness of movement. This whereby there is decrease in the movement pattern, movement of the limbs. Then balance problems. They become unstable walking or standing. Then changes in walking. The walking pattern that are developed by the Parkinson's disease clients or patients is usually the scissoring or shuffling gait. They walk faster, but then they stop and then they feel loss of balance and may fall. Or they walk slowly but making small steps. So small steps that are made faster or slowly by small steps with instability. So that is what happens with changes in walking pattern. So the common symptoms with the Parkinson's disease, as I have said, include tremors, muscle stiffness, slowness of movement, balance problems, and changes in the walking pattern. But usually Parkinson's disease affects more than movement. It usually affects more than movement. It can also influence your mood, your behaviors, how you behave, then your sleep pattern, the quality of the sleep that you get, energy levels, your energy levels decline, then cognitive function. Things like doing basic arithmetics usually is a problem with Parkinson's disease. Memory, that is the higher functions of the brain. So the common symptoms of Parkinson's disease, as I have said, we have tremors, muscle stiffness, slowness of movement, balance problems, and changes in the walking pattern. And I have said that it affects more than the physical aspect, but it also affects the psychological, that is the mind. It affects the mood, the sleep, the energy levels, and cognitive function. So understanding this holistic impact is essential for both the clinicians and patients. Usually the patients deserve to know what happens with the diseases that they have. So explaining this to them is very important for both the clinician and the patients. So why is physiotherapy essential? So global bodies like the World Health Organization, global bodies like the WHO emphasizes that rehabilitation is key in chronic neurological disease management. They emphasize the key role that rehabilitation plays in neurological disease management. So physical therapy will focus on, number one, maintaining mobility. So movement prevents stiffness and functional decline. So we maintain mobility. Remember, one of the common symptoms that I have talked about is muscle stiffness. This is whereby they develop what we call the cogwheel rigidity and the lead pipe rigidity, affecting both the upper and lower limb. So maintaining mobility will prevent that stiffness to occur. Then functional decline. They become functionally independent. That is the target. So that was the reason. That is the reason why we focus on maintaining mobility. Then number two, improving balance. So falls are a major concern, and targeted therapy reduces the risk of falls. So as I talked of other common symptoms, we have balance problems and changes in walking. So we improve balance through training in the balance and coordination exercises through targeted therapy to reduce the risk of falls. Then number three is preserving independence. So daily function is the ultimate goal. Everybody everywhere deserves to be functionally independent in doing their activities of daily living, and that is why we target to preserve the independence, daily function being the ultimate goal. Then number four, enhancing the quality of life. So confidence improves when mobility improves. Your confidence will improve with an improvement in mobility. So for clinicians, early referral will lead to better outcomes. If in case you experience or you come across patients or individuals that experience such symptoms, early referral will lead to better outcome. Then delayed rehabilitation increases disability risk. So usually Parkinson's disease develop in stages. There's what we call the yaw and hand stages of Parkinson's, where they progress from independence to complete immobility. So delayed rehabilitation will increase the risk of progressing to disability. So those are some of the goals or the key focus areas that physical therapy will focus on. I have said we have maintaining mobility, improving balance, preserving independence, and enhancing the quality of life. So let's look at the core physical therapy goals. So for the patients, the goal is to stay active. Usually we advocate for staying active. You should be independent in the activities that you do. Then another goal is to prevent complications. Uh, we target prevention of the disease progression. Usually we have the disease develops, then an impairment develops, then disability to handicap. So that is what we prevent. We prevent the complications that may lead to progression to disability or handicap. Then maintaining confidence. We need to maintain the confidence in order for us to uh, be sure with the activities that we do. We need to maintain confidence. So those are the core goals for the patient: staying active, preventing the complications, and maintaining confidence. And for the clinicians, we have individualized assessment. So every clinician should do their own assessment, individualized assessment. Remember, everybody, we do not always have to follow a structured procedure during uh, clinical assessment. Every clinician should do their own individualized assessment and come up with their own goals. Then we have functional goal setting. The goals should be set with the help of the patient. So functional goal setting. Then we have evidence-based intervention. So this is whereby we use the intervention procedures or the therapeutic procedures that are used should be based on evidence, should be based on evidence that research has shown to be of benefit to the client. So those are some of the core goals for the clinicians: individualized assessment, functional goal setting, and evidence-based intervention. So what are some of the key rehabilitation pillars? Number one, we have maintain mobility training. So we always train on the mobility. Then strength maintenance. The muscle strength should be maintained. Balance retraining. This is done to prevent the falls. And gait optimization. Gait means the walking pattern. So we optimize the walking pattern. Remember I said in Parkinson's disease, the gait that they usually have is the scissoring or shuffling gait. So we optimize their gait or walking pattern to ensure that they have a normal walking pattern. Then postural correction. We correct their posture. This can be done through various techniques. So those were the key rehabilitation pillars: mobility training, strength maintenance, balance retraining, gait optimization, and postural correction. So consistency is more important than intensity. You should always be consistent with the rehabilitation that you do. You should always be consistent. Then let's look at the exercise approaches that work with Parkinson's disease. The exercise approaches. So number one, we have what we call amplitude-based movement training. Amplitude-based movement training. So encouraging bigger, deliberate movements. So this is whereby we encourage the patients to do deliberate, bigger movements. Remember I said they have rigidity or stiffness, and their walking pattern, there's slowness in movement. So we encourage bigger and deliberate movement. For examples, while they are walking, we encourage larger arm swings. We encourage them to move their arms through a larger distance, so larger arm swings. Then longer steps, we encourage them to take longer steps. We encourage them to take longer steps even if it is slow. We encourage long steps to prevent that slowness of movement and decrease in the steps that they take. Then upright posture. So we usually use biofeedback, and this whereby we use the mirror. We place the mirror in front of the clients, and they can observe their posture as they are upright. So upright posture. So this counteracts the movement reduction. This will counteract the movement reduction. So number one, I have talked of amplitude-based movement training. So this is where you encourage bigger deliberate movements, for example, larger arm swings, longer steps, and upright posture. This is done to counteract the movement reduction that occurs with Parkinson's disease. Then the second exercise approach that is done is balance and falls prevention. Balance and fall prevention. So the essential strategies that are used here include weight shifting exercises. So this is whereby we shift the weight. For example, we can shift the weight to one leg, standing on one leg, standing on uneven surfaces, of course, with the support of the clinician. So this is where we do weight shifting exercises. Then direction changes. We change the direction of movement. They can walk towards the left, then we change the direction of movement. Then dual tasking. This is whereby they do not only engage in one task, they engage in several tasks. For example, as they can be doing posture correction while checking at the mirror, we can also encourage arm movement. So that is what we call dual task training. So those are some of the essential strategies with balance and falls prevention. So for clinicians, they should include reactive balance training. They should include reactive balance training. Then the third exercise approach is strength training. Strength training. So this focuses on lower limb strength. We focus on the lower limb strength and core stability. Lower limb strength, core stability. The stability of the core muscles. The core muscles are usually the abdominal muscles that help maintain the upright posture. Then postural muscles. The postural muscles are the muscles that maintain the upright posture. These are usually the trunk muscles, the muscles of the thorax and abdomen. Those are the postural muscles. So those should be the focus area in strength training. Lower limb strength, core stability, and postural muscles. So strength will support safer mobility. So that was the third exercise approach. Then the fourth exercise approach is aerobic exercises. So examples of aerobic exercise include walking programs. So this whereby they walk for a longer distance. It doesn't matter whether they take it slowly or faster. They engage in walking programs. Cycling, this whereby they can use either a static bike or the normal bike. Then swimming, they can also engage in swimming activities. So the benefits with aerobic exercise include cardiovascular fitness. This is whereby there is improvement in the blood flow within the body from the heart. Then mood improvement in the mood and neuroprotective potential. The neuroprotective potential. So those are the benefits that are associated with aerobic exercises. So those were the exercise approaches that are commonly used. So we have amplitude-based movement training, balance and force prevention, strength training, and aerobic exercises. Then let's look at gait and functional training. Gait and functional training. So the common walking challenges that are experienced with Parkinson's disease, we have shuffling gait, as I have explained, reduced arm swing, and freezing episodes. freezing episodes. So those are the common walking challenges that come with Parkinson's disease. Shuffling gait, reduced arm swing, and freezing episodes. So effective physical therapy strategies here will include rhythmic cueing using auditory and visual output. Then you have step length training. So step length is the length that you take from the time one foot steps on the ground to the time the other foot steps on the ground. So that is the step length. So we train on step length. We train on step length. And that is what I talked of under the amplitude-based movement, where we encourage bigger deliberate movements. Then we have turning practice. So we train on turning, whereby you walk towards the left, then you reach a certain point, then you turn abruptly. Then functional mobility drills. We train on the functional mobility drills. So those are the effective physical therapy strategies under gait and functional training. Rhythmic cueing using auditory and visual output, the step length training, turning practice, functional mobility drills. So for the patients, practice should be done regularly and not occasionally. You should practice regularly and not occasionally. Then we have posture, flexibility, and pain management. So postural changes that occur with Parkinson's disease include forward trunk flexion. So this is whereby your trunk moves forward. They usually have forward trunk flexion with the rounded shoulders. Then reduced spinal mobility. So this is whereby the spinal mobility decreases, and shoulder stiffness. There is shoulder stiffness. And this whereby I talked of the cogwheel and lead pipe rigidity. So physical therapy will help through stretching programs. So this whereby they do slow, sustained stretches. Then postural awareness training using various techniques, and manual therapy where appropriate. So manual therapy involves the use of the hands. So we have things like proprioceptive neuromuscular facilitation. That is an example of the manual therapy skill that is used. Then pain in Parkinson's disease is often under-recognized, but it can be treatable. So if you experience pain during the sessions, you should report to your clinician immediately. So that was on posture, flexibility, and pain management. So the postural changes that occur, as I have said, include forward trunk flexion, reduced spinal mobility, and shoulder stiffness. So they usually have forward trunk flexion with rounding of the shoulders, usually what we call the upper yonder syndrome. Then let's now look at the multidisciplinary approach in the management of Parkinson's disease. So best outcomes occur when physical therapy integrates with the neurology care. So they should seek care from the neurologist, then occupational therapy. Remember, in the rehabilitation, I usually say that the physical therapy at the blacksmiths, while the occupational therapists are the goldsmiths. So occupational therapy focus on the fine movements, the fine motor movements. Then speech therapy. So this is whereby we involve a speech therapist to train on the speech if there's a problem with the speech, and also psychological support for the patient and the family. So patient education is always central in rehabilitation. Patient education is central. So organizations like the Parkinson's Foundation emphasize on patient education, exercise, and community support. So they encourage the community support. They encourage the development of health to the community level. That's why they encourage community support to reach almost everyone wherever they are. Then here are some of the daily habits that may help. Here are some of the daily habits that may help the patients or the clients. Number one, we have stay physically active. You should always stay physically active. This is important for your functional performance and independence. Then avoid prolonged sitting. You should avoid prolonged sitting and sleeping. Then practice balance exercises. So you should always practice the balance exercises as you are taught by your clinician. Then maintain social engagement. You should always socially engage with your friends. So this is important for your psychological aspect. Then prioritize sleep and nutrition. You should always focus on good sleep and good nutrition. So the small daily actions are always what create the long-term impact. The small daily actions create long-term impacts. So Parkinson's disease presents with challenges. Parkinson's disease presents with challenges, but it does not eliminate the ability to improve your function. It does not eliminate the ability to improve your function. Physical therapy will offer you hope through movement, independence through strength, and confidence through education. So for clinicians, early intervention will change the outcome. Early intervention is always important as it prevents the disease progression to disability or handicap. It will change the outcome. Then for patients, consistent movement is powerful medicine. Always engage consistently in your movement. So stay active, stay supported, and keep moving. Thank you for your time. So if you have any questions, you can drop them below, or you can contact me through the email address in the description. Thank you for your time.